basically. But that didn't carry on working about that. And it's a great joy to see you now. I think I've got several new people to welcome. I can't remember if my fellow cabinet member Lee Scott was here last time. Were you?
No, John. Last time I wasn't invited.
Yes, was your first step. I thought that. The warm welcome to you. So Lee is the second councillor. Tom Abel is the chief executive of the South Essex Care for. Tom, it's nice to see you here as participant. You've been here for on behalf of the ambulance service. Thank you. One of our virtual casualty speakers is at the moment Yvonne Rees, who is from the chief executive of Harlow District Council. So we'll be welcoming our chief executive, so hopefully we will bring her in soon. And we have various other substitutions round, like there might be many new permanent members. And I do also want to welcome Hannah from Suffolk, who will observe. So that's your orchestrating quick round. Do you want to start, Will?
Yeah, okay. I'm Will Hooper. I'm a cabinet advisor for John State.
Jasmine Langley from
Ian Davidson, Chief Executive from Tendering District Officer and Vice Chairman.
April Merlin from Policies and Partnerships.
Deborah Steers-Angus, Independent Chair, Essex Safeguarding Board.
Susanna Howard, Integrated Care Partnership Director at Suffolk Wellbeing Sussex.
Rebecca Jarvis, Alliance Director, South East Essex, MSE.
Mike Thorne, Chair, South Essex ICB.
Emma Davey, I'm the Primary Care Board Member on the MSE ICB.
Tom Abel, Chief Executive in South Essex ICB.
Councillor Kaz Risby, Eccles Forest District Council, portfolio holder for Community Health and Wellbeing, also a GP partner in West Essex.
Thank you.
Councillor Lee Scott, Cabinet Member for Planning and Growing Economy, Essex County Council.
Councillor Graham Butland, Braintree District Council, representing the Mid Essex Alliance.
Will both Chair of Suffolk ICB.
Hello, everyone. I'm Director of West Essex HCP, sitting in for Tony Fox.
Thank you.
Director of Public Health.
Chris Martin, Commissioner Election, Chief Services Secretary.
Hi, I'm Greg Middleton. I'm the Strategic Head of Partnerships and Delivery at the FCC's office here on behalf of my journalists.
Okay.
Lisa Farrell, Director of Operations, Essex John Town Wellbeing Services, the Project Sharing Education. Councillor Beverley Dunn, Chairman of the Caring Communities Committee.
Andrew Graham, South End Essex and Borough, Learning from Lives and Deaths, local area contact.
Okay.
Will Herbert, Head of Integration and Partnerships at the CC.
Shannon Rotter, Head of Policy and Partnership.
Okay, thank you all very much. I also have such a responsibility when I listen to all of you and the important jobs you do, so we need to make best use of your time. Apologies, Jasmine, that haven't been given over to.
Baby, but doing much elderly, Dr. Chipman, Dr. Ian Perry, David True, Amy Coles, Elizabeth Kirby, it's substituting and Classic Vicky Davies. And Tom Walker.
So we can imagine how full the room would be if everybody was there. Fine. The minutes have been circulated. Are we all content of an accurate record? Good. And back to the right thing, I am aware of none that need to be addressed today, but I'm about one other thing. Any actions? No, you're quite right. So what we should have done as under, particularly under masterising, is fulfil the obligation to formally endorse the Q1 report on the better care, which was submitted on the 29th of August. I apologise if it was only circulated too late in the afternoon.
To read out if you have any points you want to raise. Otherwise, are we content to formally endorse it? Reads fine to me and it has gone in.
Great.
Okay, thank you. So we come then to the health and wellbeing strategy, your strategy adopted by this board. And we've been at the halfway point, undertaking a review. So I think, Ian, you're going to introduce this. There is a call for action, which we need to be very clear on whether we approve later, because we actually need a clear mandate on the proposed way forward. Ian?
John, good morning. Good morning, everybody. And first of all, a huge thank you for all of you who took part when we did the review around the health and wellbeing strategy. So we agreed at the board previously that the joint strategic, Essex Strategic Coordination Group would be looked at and take forward the role of looking at the health and wellbeing strategy and coordinated a workshop. The first workshop we tried to do actually got a general election happened to get in the way, so we had to move it back. And the second and so we rearranged that, and as a result of that, over 40 people attended. Really pleasing to see, and it showed the commitment around the importance of the health and wellbeing strategy. It showed the kind of the diverse commitment, because the number of partners coming from different organisations to wanting to talk, wanting to contribute, wanted to tie up with what they were doing, and was really important. And for each of those who attended, thank you very much indeed. And I know others actually had input via people who were there. And I'd also like to thank the team, Nathan, who sat next to me, for all the hard work they did in coordinating that and bringing that together. The health and wellbeing strategy, I think, is a really important one, because it is a coordination for Essex around across Essex around the well-being, and so much of what we talk about is around the how can we proactively, even if you look at from the pecuniary point of view, how can you proactively reduce the cost of the care and the health for our residents, as well as for the improvement of lives and making the outcomes better long term. So the priorities which were adopted in 2022 were improving mental health and wellbeing. We know that's a big issue for Essex, more so for some areas. Physical activity and health weight, supporting long-term independence, alcohol and substance misuse, and health inequalities and the wider determinants. So what we wanted to do was look at a midpoint in 2024, how far we've got. Were we actually doing anything with it? Was it something that was just sitting on the shelf and actually was getting a bit of dust every once in a while? Or was there achievements which are going forward with it? And I think that this is not a strategy which is going to solve all those issues in 4 years. This is a lifetime, but if we're improving on it, you're going to make a difference to people's lives. So some of the key challenges which came from the Joint Strategic Needs Assessment and the JSNA, you always hear me say this, but plugging it is a fantastic document for any organisation to be using that as a point of reference. And it's not just about the health, there's well-being in there. There's a whole myriad of other terms. I see Greg sit at the back there, and there's also the link up with our other partners as well, and local government. The improvements in life expectancy have actually slowed, and the gap in health life expectancy between the best and worst areas has increased. You'll die, but being blunt, I know that there's nuances about this, but let me just use very emotive language. You'll die 18 years younger in Clacton, in the most private ward, than you will over in Saffron Walden. Now, that's in one county. So that's sort of some of the issues which still face us around the life expectancy. We've got increasing numbers of children and young people who are presenting with social, emotional and mental health needs across a range of different settings. The adults with severe mental illnesses have over a 410% higher risk of premature mortality. And this is increasing. So this is not something where we're kind of saying is that recognising this, but it actually is increasing. Over a third of year 6 children and 7 year 6 children and 7 in 10 and sorry, start again. Over a third of year 6 children and 7 in 10 adults in Essex are overweight or obese. And this is predicted to increase. So that reflects back on the priorities which we adopted in 2022. There's issues about how often Essex children meet physical activity levels, and 1 in 5 adults are inactive. And there is some great work going on, and we'll talk about that in a minute, you know, such as the Active Essex work, the work that we're seeing across by different individual schemes. But as our health and wellbeing strategy is coordinated, what is our impact on that? There's been a significant increase in residents struggling financially, with 1 in 10 pushed below the poverty line. That's due to the heating costs, and obviously a fifth of all children, our school children, are now eligible for free school meals, which is a significant figure when you think about 1 in 5. Every classroom, there's 1 in 5 children in there. Narrow it down to that. I think about, you know, children in the school that my children went to, and you think around that classroom now. Smoking rates are increasing when we were seeing that dipping before. But looking at some of the overall improvements, and it was really interesting around with the workshop, just how proud and how much work had gone into delivering some against this. So, you know, this is not that there is nothing happening. This is not that there is not significant improvements in the areas of around our priorities. And there was some great work, and and you will see in the report in your pack that there is a tables in there of some of the work that have been done right across the county, and some successes. But some of the overall life expectancy is slightly higher than England. So Essex, as we know, is a very diverse picture, and has actually returned to the pre-pandemic levels. And again, that for some parts of Essex, that's the diversity of our challenges, the socio-demographic differentials. One of those ones which as a board, we've led with, and I don't think Jane Gardner's here today, but as chair, this is about suicide rates have started to decline. We had the 2nd, 3rd and 5th worst areas for suicides in the country. And that is turning around, and that is only turning around because of focus, because of saying in the strategy that this is something we're really going to focus on, and putting our work behind that. So when you look at that, is that they've started to decline, and a significant number in Essex, then across England for the first time since 2007, 2009. So that's a massive difference. And just sort of taking a moment on that one, and one of the reasons why I'm so passionate, I have a personal reason around also focusing on the suicide, the impact it has on families, the impact it has on the wider sector in terms of support, the impact, lifelong impact it has, is almost unimaginable. So to see that change in isolation is absolutely is brilliant to see. Physical activity is increasing among children and adults in Essex. So that kind of sounds as though it's contradictions with what I said earlier, but the overall figure is increasing, and children's diet is improving. I think that the levels of visually obvious dental decay in children has been increasing. That's interesting in terms of when we hear about the issue around the access to dentistry. But we've got things like in Southend with the school, which has given the additional outlets for dentistry for people, and along with the hospital admissions for dental care among 0 to 5-year-olds. Levels of death from drug misuse are decreasing. Most of the counties, along with small reductions in admissions for alcohol and related conditions. I can hear Greg from the PFCC's office in my ear saying, but overall, the number of actual people who have been stopped and been prosecuted, it's a higher number of drugs than it is drink driving. So it's drug driving, which is higher than drink driving now. So it is still an issue, but the overall picture around that is around it decreasing. The health index in some of our most deprived area has improved. And if I may, just going to be parochial just for one moment. I've tried not to be for the whole thing, but I'm just going to be for a moment. So Tendring has the most deprived area in England, and some of those health issues are some of the worst. For the first time ever, it has improved by 4.7%. It doesn't sound a huge amount, but when you look about nationally, it's only 0.8%, and in many areas it has actually declined. So again, that's not randomly happened. That's because of focus. That's because of the work as a result of the strategy, because of the work of the county health and wellbeing strategy translating itself into the local health and wellbeing strategy. And I know that many people here will say that that's what they're doing across the one, and absolutely rightly. I'm just being parochial and just giving an example. So pardon me for just sort of taking that moment, but it just shows when we get the health and wellbeing strategy right, and by right, I mean chiming at a local level, chiming with our partners, chiming with the kind of the work we're doing. That's when it translates into our local policing, our local councils, our local fire service, and obviously our health service. And I'm using other partners because actually health and wellbeing is everybody's responsibility. It's not just what are you doing about it, it's what are we doing about it. Re-ablement services are increasingly and more social service care users are satisfied with care and support. And that's interesting because actually in a lot of places that's not the case, and certainly post-COVID. So that's sort of some of the movement. Delivering against the strategy. So on our first priority is about improving mental health and wellbeing. There are really some strong strategic partnerships. We hear criticism sometimes around the mental health and the support, but actually there are strong partnerships which are much wider in recognising the issues around mental health and the support around mental health. It's not about for the mental health services, but around holistic. And that's the work councils can do. That's the work obviously working with for example, the policing, having a mental health worker on a Friday night in a policing car. Sorry, Greg, I keep seeming to be picking. But I'm just trying to express the diversity of the importance of partners, not that it's individual partners' responsibility. Partners have established the Greater Essex Implementation Group Mental Health, and that's Southend and Thurrock, and the Thurrock Suicide Prevention Partnership Board. And again, actually linking up the Greater Essex. So it's not just about what's Essex and what's Thurrock over there and what's Southend. We have our own health and wellbeing boards, but actually, how do we integrate that as a wider sector partnership? What are we going to do though in that area for years 3 and 4? So that's the kind of the 1 and 2 reflecting back when you bear in mind we're halfway through the strategy.
So shall I just pause you there because you're about to go into the future? Any questions or comments on what Ian said so far about the progress in years 1 and 2 of the strategy period? Ian, so yes, move on to the forward-looking piece.
Usually find people think, no, I'm not going to ask a question, he'll speak more. So too many of you laugh and knew me too well there. For years 3 and 4, I'll just go through the priorities on the potential for the improvements, because we've highlighted some of the priorities, different things in terms of strength there. But for years 3 and 4, focus on children and young people's mental health, around the inequity and the related health inequality for people with mental health conditions. You know, organisations like people at the local level are seeing that vast increase in terms of the demands. They're also finding it more difficult to get people to come through the door. They might do it online, but actually interact. So having that focus, I think, is picks up. And what these are things already in the strategy. We're not rewriting the strategy. We're just saying, what do we focus on for year 3 and 4 and the importance of that. The creation of a new Southend, Essex and Thurrock all-age mental health strategy. And I think that's so important about that, recognising the Greater Essex economy, and I mean the health economy and the kind of the well-being economy for our people. Essex Partnership University Trust's suicide prevention programme. Whilst it's good to see that we've had an impact on our suicide rates, it actually is by no means should we be complacent and stop there, because that's when it's, as soon as you do that, that's when it starts to slip back. And there are a number of determinants which will be pressures on people, which are the sorts of things which are potential for creating the issues which may lead to people taking their lives. Older adults, mental health transformation in Herts and West Essex, along with a focus on wider determinants, and including that around housing and employment. You know, as district council, knowing the housing and knowing the kind of the condition of housing and what impact that has and what role they have. And I think that for us as district councils, for example, we need to better develop that, talking to our housing officers, both in terms of housing conditions, but also recognising when they are visiting. PFCC trauma informed care programs, including through the violence and vulnerability program. I will give a plug around the violence and vulnerability program. It is pretty unique in terms of the extent of it across the country, and it is nationally recognised. And that link between the violence and vulnerability work and board and the work across for supporting people, not just about reactive but proactive, is exactly the same as the messaging around the health and wellbeing strategy about being proactive and taking forward rather than reactive. So credits to and pass by Greg through to policing around the violence and vulnerability board. For priority 2, what actions for years 3 and 4? So Active Essex will be leading on the delivery of the Fit for the Future implementation plan. In our area, they've already given out over 1,000 bikes. That sounds nice, doesn't it? Get people active, get them on the bike. But it's far more than that. It's about social isolation. It's about getting people to work, actually, because we do abduction in buses. It's about a much wider range of the well-being for people, which they have made such a difference to. There's a whole myriad of other programs, and if Jason Fergus was here today, he could take up the rest of our talking about that. But it's a whole level of things with levelling up health and wellbeing, supporting the support and physical activity sector, strengthening communities. Laura Taylor-Green's here today from SNE, and we've been talking, and we're developing around how a wellbeing hub, a holistic one, which is looking at about how sport plays a part along with sitting alongside health and sitting alongside the opportunities for linking up. Work to deliver a healthy weight strategy, which will include focus on developing a local capacity and capability, as well as specific asks of local public health practitioners and stakeholders. It's not just a kind of a passive, this is what it is. There needs to be the ask of engagement and to make a difference. And I think that's one of the things in terms of strategy, as John said, about what are the asks about what do we take back to our respective organisations, our respective health areas, in order to say these are the asks to make the health and wellbeing strategy continue to be a success for its second 2 years. And also partners will be establishing an Essex Healthy Weight Advisory Group. And it's great to have that, but it's only successful if then that's taken into organisations as a result. Supporting long-term independence, the implementation of the Meaningful Lives Disability Strategy. That will set out Essex County Council's commitments to make the county more inclusive place for our residents with disabilities. I can hear in my ear John talking quite rightly about people becoming economically active and actually both in terms of the economy, but also in terms of for health, well-being for all of our residents. And also exploiting, and I use the word on purpose, there's skills which are on offer, which we're not exploiting our full workforce. So, the whole myriad of things there. Evaluation of falls care services in Herts and West Essex and implementing revised models. We were having a conversation about that the other day, and really interesting. And of course, falls and cares, not getting that right, actually, the reactive cost to health, as well as the importance for stopping falls and for those, but also then the reactive implications as well. Implementing the next phases of the Herts and West Essex community diagnostic services, as well as the implementation of new clinical pathways for residents with ADHD and ASD. And an evaluation of autism spectrum disorder, which I think, and you've heard me talk before about the importance of our work around autism, the opportunities and the great skills which people with autism have and maximising that offer. So I think and again, that is across Essex, Southend and Thurrock as well. And again, it's about the greater Essex economy, not just about our bit of it, or Essex, or just Southend, or just Thurrock. It's about how do we look at it much more holistically. Alcohol and substance misuse. The Southend, Essex and Thurrock Drug and Alcohol Partnership are preparing tenders for the new renewal of 2 key services across Essex, which is the Community Rehabilitation Programme and the Non-Medical Alcohol Service. And I think in terms of the health and wellbeing strategy, it's supporting those sorts of pieces of work, which actually is what are the outcomes which we will achieve for our strategy to say, actually, our strategy was relevant to what was the challenges for others. And I would add, Craig, I seem to be picking on today, but I'm going to add you to that. I would add also for 3 years 3 and 4, how we also within policing and that link up which we were talking about earlier around the drug misuse as well. So I think that's and I know that work is going on around the Violent and Vulnerability Board because I sit on that as well. So it's I'm making that. Health inequalities and wider determinants of health. So partners agreed that there needs to be an increased focus across the system on the wider determinants of health in order to address some of the underlying quality, the inequalities that contribute to poorer health. I think that that's one which is still one of those where we need to develop about how we are going to do more to really get beneath the surface of that, how we really kind of understand that and what's the next piece of work. And actually some of that work is about taking that from the county-wide health and wellbeing strategy and translating that into local health and wellbeing boards. And I think some of the conversations which we have here, we need to find ways of better translating those at a local level, at the local health and wellbeing boards, so that the work can support each other rather than it being in isolation. That is one of those ones there, because health inequalities are not exclusive to Basildon, Harlow and Thurrock and Tendring. There are inequalities in the affluent areas as well. So understanding.
Coming up to 20 minutes here.
Yep, I'm just coming up to the key challenges in monitoring so far. I think that the levels of activities we've been capturing, I think that the next phase is about how we make sure we capture that. I think it's about recognising the importance of the range of partners in delivering the service on the ground. And it's definitely about not saying to health or to the Essex County Council and to Jyoti as Director of Public Health, oh, how's it going? Actually, it's not how's it going for you. It's about what are we doing about it? I think that's the messaging. And I think we need to use more boards on it. I think we also need to try where we are representatives on this board, but we are also representatives on other boards and taking that to them and talking about the health and wellbeing strategy at what I'd call the not the bleeding obvious partnerships where actually, why are you taking that here? Well, actually, I'm taking that here because it's relevant to what you do. I'll give you just one example, the Essex Housing Officers Group, the Essex Housing Officers Association for the private landlords. How do they understand what's in there and what's relevant to them? And I think that's our responsibility collectively as individuals around this table to say, actually, we'll take a summary and we'll take it back. I've got a very edited set of slides here, which we can circulate afterwards and use those to take anywhere. I'm happy to go along to boards if you want me to come and wax lyrical. Be careful because I do go on a bit. So you might regret that, but I'm happy to also represent because I think this is just so important. I think we've got to make sure that the health and wellbeing strategy is relevant and what we're talking about here. And it touches every one of them, the areas of support we give. And then finally, the current hands-off approach to coordination monitoring needs to be more rigorous and better reflective of how delivery is happening on the ground. How do we kind of then capture some of that? And it doesn't have to, and it's not about having a monitoring system where everybody's feeding in figures, but it's about understanding what we're actually doing and when we're not doing it, and so when we need to give focus to it. And the best example I can give very quickly on that is around the suicide prevention and what a difference it made when we did it. There are various other ones. So that's my very quick run through of the work around the health and wellbeing strategy. Thank you again for all of it. I'm going to pass over to Jyoti because there were just some proposals to improve around the coordination and delivery, which around creating and identifying system champions. Because if we want to genuinely do this, leaving it passively on as a document and not having a champion is not, it won't go anywhere. If we identify the champion and what it means. So Jyoti, do you want to talk a bit about that?
So the proposal is that, we recognise the great work that's happened so far, but we think we could go further if we were more coordinated, had clear measurable goals that we were working towards or ambitions that we're working towards, and have stronger leadership around the delivery of the 5 priorities. So the proposal is that we identify a senior responsible officer from across the system. That wouldn't necessarily be the subject matter expert or someone from the directorate. supported by an appropriate professional. And that we identify an appropriate multi-agency forum. Many will already be existing. We take the work through, that group would identify clear, measurable, time-specific visions for each of those priorities, develop coordinated action plans, and bring them back here, not just to report on progress, but also to challenge and ask for support where it's needed.
Okay, so we are asked to endorse the approach, and endorsing the approach indicates to me that you will each in your own organisations be ready to consider who might be the SRO for a work stream so that we can populate these. To endorse without being ready to act is a bit of an absenteeism. So any questions or any discussion about what Ian and Jyoti are proposing on the back of a workshop with 40 people, let me remind you. Sorry?
Helen Lincoln, Becca Jarvis.
Helen, then Becca.
Just to say, I really welcome the kind of children, young people focus that you're proposing. I think that's really, really helpful. We do have the children's partnership boards and the Start Well stuff within the ICB. So it's kind of just, we can link that in. I think that could be really well coordinated.
Thank you. Rebecca?
Yeah, thank you. So really helpful. And I think it is good to see the priorities and the approach, Jyoti, you referred to around coordination. My only kind of reflection is this, in a positive way, links so much to our alignment with our ICP, our local health and wellbeing boards, but also our alliance delivery. And I just want to make sure that we are using the coordination rather than just setting up additional layers of groups and governance to be able to focus on the strategy and not necessarily the delivery. So yeah, I just think that there needs to be some more thinking about how we use our existing levers to deliver on this.
Yeah, I completely agree with that point. Yeah.
You know, Becky, I will just hate having more and more pieces. This bit's got to be about enabling and facilitating. And so much of this is about importance of communication. We can't have different bits doing different things. We can't afford it apart from anything else, but it's all the frustration of inefficiency. Anybody else?
Susanna.
Susanna Howard?
So thank you very much, Ian. I mean, first of all, can I just say, you know, I'd like to take you up on your offer of coming to share the health wellbeing strategy, because I think that not only, you know, it's really, really important, as Rebecca says, to align it to our ICP, but also there's a lot of learning there. I think in terms of what's worked in Essex, which we could share more widely. The other thing is that I just really wanted to support and underline your point about taking the strategy out to wider forums, because it's a really clear articulation about what the health and wellbeing and the kind of depth of kind of, you know, the issues that you need to embrace there. And I think the more that we can, you know, work collectively to help educate and to integrate health and wellbeing throughout wider strategies, the better.
You were suggesting taking it out to wider forum. Would you have anything specific in mind?
I was just thinking about, I mean, so some things we think moving forward, you know, houses to be built, you know, roads, you know, those sorts of things. The more we can, you know, really kind of collectively as a health and care set of partners, educate, you know, everybody about what really kind of keeps our population well, you know, I think the better really. And, you know, there's a lot of work gone into this, but it also then does make some really kind of key points that might not be that well understood in other sectors.
Thank you. Is anybody objecting or really worried, apart from Rebecca's point, that we mustn't allow it to become another fragmented part of a fragmented system? Because if not, I am about to ask. Sorry?
Ian's going to come in.
In a second, I'll bring you back in. In a second, I'm going to be asking you to endorse the approach, which I'll remind you will lead to an action point for every one of us to take away, so that we ensure that the SROs are populated and that we are working together. Given Becky that commitment to communication. Yeah.
Sorry, John. Couple of things. John, to pick up about your point around alliances, and I think that's a really important one. Because at a more local level, we can actually get to a wider set of partners who don't come to the Health and Wellbeing Board, but they do come at a local level, but they're still quite wide as alliances. And I think that they are a really valuable place to go and actually have some of this discussion. I think that in terms of the point which you made, John, about it not being another layer, I think this is something which will help us champion those things at a local level. It's not that you're going to do every line, but actually it's making champions. But picking up Susanna's point but where is the best practices and where can we learn from each other and what's in there? The table in the actual report gives quite a lot of different examples. And I think that when I read it, I thought, oh, that's interesting. I need to find out more about that. And Ian and West about some of the bits. In fact, our teams are getting together on Monday just to have sort of some of those conversations. So it's that opportunity to use that. And the sorts of things where actually how do we disseminate it? There is one of the suggestions I was going to make is for councils, local councils who never get to see this because they don't even go to the local health and wellbeing board apart from a representative in those, is have some kind of online workshop where they can join and we can set it up as a county-wide online workshop. I haven't even had a chance to talk to you about this, John, so apologies for springing that on you. But I think it would be useful just to sort of perhaps have that opportunity to talk to the council about what's happening. For some councillors who are engaged in their local communities won't even have been exposed to this information. They've been exposed to what's there. Never mind knowing then what's in the strategy and what part they could play. So I think that there's a whole raft of layering which in terms of partners, and it will also make sure we are consistent with our message as opposed to rather than as you said, fragmentation.
Yes, Ian, I'm very mindful that each of our integrated care boards has its own strategy. Yep. We talk about alliances. Alliances are the place where they decide the priorities within the realms of the ICB strategy, informed by the county health and wellbeing strategy. There's actually very little difference in tone, but it's always going to be the importance of the alliances, which is where you get that local shaping taking place. So I will always have full respect for the ICB strategies, as I know they do for the county. Yes, Will?
Yvonne Rees online has put a hand up.
Hi, Yvonne. Good morning and very warm welcome. Sorry about the difficulties we had in getting you to join. I hope you're hearing all right.
Oh, I'm hearing fine. Can you hear me?
Yes, very loud.
Awesome. Sorry, and apologies for not being with you. Logistics just made it impossible. I just really, I think, want to echo what Ian has said. I think the strategy is amazing, sort of having come quite recently to Essex, but also what I would say is I would like to see a greater connectivity between the work of this board and down into the individual health and wellbeing boards, and would really endorse what Ian said. I think it would be really helpful if we could spread this information much wider with potentially some councillor sessions and councillor seminars. I think it would be of real benefit. So really just to endorse that which Ian has said and just cry out, I think, really for some greater connectivity.
No, well, thank you, Yvonne. And if I might ask you and Ian's help here, because it was the case pre-COVID that just a couple of times a year we brought the local portfolio holders, so chairs of the local health and wellbeing boards together for a conversation stroke debate, not on our agenda. So that has we've never been able to revive it post-COVID. If we could do it, Ian, and do on it would be just, not another layer, but an area where we can sort out any things that need to be sorted out. So I'll leave that with you. Anybody else? Yes, Will.
Yes, you've got Councillor Kaz Risby from Epping Forest coming as well.
Thank you very much, John. And just to say a big thank you, actually, I'm very thrilled by what you've just mentioned. I, of course, am the portfolio holder for Community Health and Wellbeing at Epping Forest. I chair our Epping Forest Health and Wellbeing Board, and also wanted to extend a thanks to Ian for the great presentation. We would love to have you come join us on our quarterly board meetings at Epping Forest. We are probably one of the more mature health and wellbeing boards. We are very fortunate in Epping Forest. We enjoy quite a wide territory in terms of sort of looking at the wider determinants of health. We have pockets of real deprivation, but also a of affluent. So one of the main goals that we've been trying to achieve as part of our Health and Wellbeing Board meetings is sort of focusing on areas of, public health. Last month, we had our board meeting where we looked at addressing issues like childhood obesity, which Ian mentioned, as well as sort of, the wider issues affected, by social housing and sort as well. So just to sort of echo what John has said, I'd be quite happy to continue attending and inviting Ian to our board meetings.
Please. You got that offer. I'm hearing nobody doing anything other than be positive, so we are asked to note the report and progress made so far, to agree the way forward in terms of how we make sure the strategy is implemented appropriately and cost effectively and in full harmony with other strategies over the next 2 years. And therefore we agree to take the action of achieving all the SRO posts being filled. Are you agreeing to that?
Agreed.
Yep. All agreed? Yeah. Right, thank you very much. Now, so firstly, I've had my knuckles wrapped by the man on my left. He does this quite often. I've had 2 knuckle wraps. Firstly, I failed to give the public safety announcement. Will, would you like to do it?
Yes, and the gentlest of knuckle wraps, more a sort of gentle advice, really. But
I was on the receiving end.
Just to do the formal bit, which normally we do at the start, to remind you that this is a public meeting. It says here we're live broadcasting. I think that might be wishful thinking. We are. It is being recorded, and will be available afterwards, so it will still be available to see. And a reminder that speakers in this room can be exceptionally sensitive. Will pick up anything. To remind you, or to say, there will be no fire drill this morning. So if the fire alarm does go off, then it does mean that we should head out following the officers and gather in the cathedral grounds, which is the place to go. And just to say that we try to allocate seating for everyone. There isn't room around the main table, but for those of you sitting at the back, if you are going to make a presentation, there is some space down here to come and speak if you'd like to. Certainly the microphones, having said that they're exceptionally sensitive, they will pick you up better if you're down here at the main table. We need to do that. That's it.
Quite long enough, I thought, thank you. And the other piece was about the audibility of the room, so that's fine. If people up the back even want to make a contribution, don't worry about it coming down, it's always helpful. I now welcome Yvonne, thank you, and I believe Dan Doherty's online. Are you there, Dan? Yeah, okay, he's not arrived yet. Nor has the BJ, the Chief Constable's he's been called away. His assistant is due to be doing the right care, right person piece. She's not here yet, or he, I don't know who it is. So therefore, we'll go straight, Deborah, to you, please. Now, the ESAB update, I hadn't quite appreciated you were going to be sent the first quarter report. The decision we need to make here, apart from receiving the plan for the next 3 years, is to understand, I need your feedback on how often you would wish a feedback, you would wish a progress report. And Deborah, it will be helpful to know how often you'd like to give us one. But Deborah?
Thank you, John. I think it might be realistic to say biannually or annually, whichever the Health and Wellbeing Board would prefer. I think quarterly is probably going to be too tight to see real progress. But I'd be more than happy to come, and I mean, I'd come to the board anyway, so I'd be more than happy to present annual or biannual, whichever you prefer, updates.
Thank you, Deborah. You've got quite a lot of paper here from Deborah. Are there any questions? We did, of course, see the plan as it went through the process, Deborah. Do we know what you're trying to achieve? Do you have easily the key outcomes from the current plan that's just been adopted, the strategy that's been adopted?
I do, yeah. I can share those today with what we've achieved so far within the first 4.5 months of deployment in relation to delivery. I can be very clear about that if that's helpful.
think it's just useful to say, I'm less interested in a way in the 4.5 months and more interested in the 4.5 years ahead, really. It's a 5-year plan, isn't it?
It's a 3-year plan.
So what will cause you to be looking satisfied in 2.5 years' time?
That's a big question. I think if I looked at some of the gaps that I felt that when we built this plan, we worked very much in consultation with our partners, and we did a really great workshop, which was well attended. I think we were concerned, perhaps, fair to say, at the beginning about some of the points that have been raised here this morning about the word alignment and not creating another layer. So we've worked really hard with the ICBs, who I thank immensely for the integration work and collaboration that they've done with us in relation to alignment of shared goals. So I think that will be a big achievement, is shared goals in relation to safeguarding. I think if I'd looked at another gap and said, what would I want in 3 years' time in relation to the work that we've done and progress we've made, and I think it's fair to say, as I've probably inferred before, that the Safeguarding Adults Board is, I think, in relation to my tenure, probably at a certain point of reaching maturity now. So we've been able to focus more. This strategy is focused more on development and fill in some of the gaps that we thought we may have had. So we've aligned very much working with Healthwatch. So thank you to Sam personally and her team for the focus that we're making on co-production and lived experience to bring that alive and meaningful. If you asked me another thing I'd like to see more of in the next 3 years, what I'd like to have achieved, and this is a long shot really, but I'm aware that we're seeing a constant increase in safeguarding referrals to our partners. And I think it's probably fair to say that some of those referrals, certainly high up there in numbers, but not always there in relation to, I'm not sure the word is quality, but maybe relevance. So some learning around what makes a good safeguarding referral, because every referral that comes in obviously has to be seen, looked at, triaged, gone through, decision made. So if we're looking at a massive increase in that, which we have done in the last few years, and it's not going away. So anything that the board can do to make referrals more relevant and positioned and poised with the right issues in relation to the concerns that are being brought up. And also sharing, another thing I would hope for would be to be able to share some of that burden, because some of the information and some of the referrals that we're getting through, I mean, Nick's on my right, he'll probably be able to tell you more, as I say, with difficulties in relation to relevance. So frequently people don't actually need a safeguarding inquiry. That they might need direction for another concern or support in another area. It depends what their primary support concern is. So another gap that we thought was some kind of opportunity to create a directory or actually utilise the frontline directory, which we're starting to have negotiations with at the moment. So I think that equality and diversity and inclusion would be on top of my list in relation to your question. A greater emphasis on peer challenge, a continued focus on strategic alignment and not creating layers, co-production, lived experience, and relevant referral making. And in relation to that, how we can support that particular part of the process by developing the learning around what comes out of safeguarding adult reviews. Because we've obviously not only had an increase in safeguarding adult referrals, but we've had an increase, as you would expect, to match that in safeguarding adult reviews. But what we're seeing, and we're not an outlier with this, I've seen this in other areas where I've worked in across England recently, is that we see the same issues come up time and time again in relation to recommendations from reviews for organisations for safeguarding. And some of those key issues, for example, application of the Mental Capacity Act in practice being a prime one, sources of neglect, things like that. So picking out some of those top things and working on those, and in the documents that you've got in front of you, I'm more than happy if you'd like me to take any questions on those, because we've started this now and we're on a wheel really. We're on a road, so yeah, all moving forward. I don't know if that answers your question.
I know it does. Thank you very much. I think one or two of the things you talked about were like what makes a good referral. We leave you to, I think, deal with officer level and then tell us what we can do to help. I don't think it's for us to be designing that. You do remind me, it's amazing when one gets one's responsibilities enhanced, you realise what we're not doing. We are not, Helen, receiving any votes from this Essex Safeguarding Children's Board, which feels a bit of a gap, really. So we'll need to address that going forward. Are there any questions or observations on the documents or what Deborah has said?
John, just a quick point, question from me. I mean, I would have thought it would be helpful to have sort of biannual reporting. And when we next have a report, I wonder if we could spend a bit more time having unpacked for us what sits behind the identification of self-neglect as an area of risk. It'd be interesting, not today, but to explore that and have a bit more detail on that, maybe when that comes back in next time.
Absolutely, I could do that.
Okay, Nick Presnick, and welcome.
Thank you, John. Apologies, I had to do something before the board, so I was a little late. So I think the first thing is that we should really just remind the board of our role. Our role is to deliver the strategy of the Health and Wellbeing Board. We're not a HOSC, we're not an oversight board, we're not an operational scrutiny board. So whilst Deborah and myself would be happy to answer questions on natures of referral, so what we're really here to do is to ensure that our systems and processes are adequately joined up and that we have assurance and that we have a shared understanding of what we think the key safeguarding risks are in our system. I would say from my perspective as the statutory DAS, I would say the quality of provision and services, I would say the safety of people in our communities and how their perception of that, and I would say modern slavery and exploitation are probably the three issues that sit across our organisation. So if we were to have a conversation or a deep dive, that would be how I would propose we framed it. And I would suggest that no more than biannually in terms of catching up, simply because Deborah has to administer a board as well.
I could see an argument for in writing half yearly, annually a full agenda item, unless something emerges which needs an agenda item in its own right. Helen, we've heard from Nick his three greatest concerns from his viewpoint, from the children's safeguarding side.
So the children's safeguarding report goes annually. The annual report goes to overview and scrutiny. That's formally that's its route. I mean, I think that it could quite clearly come as another report here. It's a second reporting space. But the scrutiny of that is overview and scrutiny, not the health and wellbeing. Space to Nick.
We do the same. We supply to the exactly the same route with our annual report.
Yeah.
So yeah, but we're reports a year behind.
Yes, exactly. It's always a year behind. Yeah.
Paul Burstow.
Yes, so just reflecting on Nick's point, and I can see absolutely the merit of taking the approach he's described. That feels a very important service lens to apply to all of this. The thing that struck me reading this report was the bit about the local areas of risk, and I'm genuinely interested in understanding not a service lens perspective, but what is meant by self-neglect in this. Not as definitionally speaking, but what is sitting behind the identification of that as an area of risk, which is not necessarily a service lens, actually more a personal lens. So it'd be interesting to not lose sight of that, given it's been specifically flagged as the first of 4 bullets in this report. So I just don't want to lose sight of that.
No, I agree. I understand that, Paul. Tom Abel.
Thank you. So I think Nick, that was really helpful, and I was wondering maybe in future reports whether we could structure the report in that way in terms of some of the thematic areas which we need to be collectively coming together to address across Essex. And the second thing for me was obviously there's been lots of good work. I didn't get a sense in terms of, are you happy with the progress that's currently being made, or is there room for improvement, or are there hurdles or people or things which are getting in the way of you being able to make the project work in terms of the delivery of the strategy?
Is that a question for me or Nick? Sorry.
Either,
Would you like my view on that?
yeah, that'd be great.
We're a very tiny team. We work very much in partnership. We couldn't do what we did or even achieve to do without the partnership support that we have. The constant dedication and commitment is unbelievable. We work on a very tiny budget. And personally, I think we exceed. I'm probably going to be biased to say that anyway, but we do, because if you just look at the progress we've made in 4 months, and that's all partnership support progress. None of those people are doing that every day for a living. They're doing that as partnership support progress. So I think that's huge. My expectations of the partners are also, I know, big, but they fulfill. And the trust and dedication and commitment always comes through. So if you wanted me to look at hurdles, resources are always a hurdle. Increasing referrals are always a hurdle. And I could go on. But for now, I think we've done a pretty good job. But I'm going to say that.
I would just respond to Tom and saying, taking the performance of the team aside.
Yes.
How the board functions. I think the board functions well, and we've got good representation from our 3 systems. We have struggled to get engagement from certain partners, such as the prison service, and that's ongoing. I think our SAR process, our safeguarding adult review process, is going well and is robust. But I still feel that our multi-agency data and information sharing of risk could be improved. That would be my strategic overview. And I think a deep dive into things like self-neglect could be quite interesting, but I suggest we do that in the board, the safeguarding board rather than the health and wellbeing board.
Well, you would do it at the safeguarding board rather than here.
Yes, because this isn't the place for it.
This has got wider aspects to it than safeguard.
Yes, no, John, I actually say the safeguarding board is the right place, and then the recommendations that come from that deep dive would come to the health and wellbeing board for a broader strategic conversation.
Oh, I see.
That's how I would do it.
Any other pieces? That's been very helpful. And thanks, Paul, for explaining that. Thank you, Deborah, for your explanation. So I think I'm inclined to suggest to you, firstly, that we get a half-year report in writing about the progress of the plan. Annually, we have a full agenda item on the clear understanding, Deborah, that if something needs to be brought to the board as a separate agenda item, we would accommodate that in addition. Are you quite happy with that?
Yes.
All right. You're happy, but is everybody else happy? If people are nodding, I'm struck. Anyway. I'm hearing.
Yes. Yeah.
Right. Okay, Paul, it's being suggested on the self-neglect piece, Jyoti, that they have an initial discussion at the safeguarding board, adults and children, please. And then a report comes here with some recommendations and things to go forward. Are you okay with that?
I'm very fine with that. I think what Nick said makes perfect sense. We shouldn't do someone else's job.
We'll progress in that way. So we will schedule, please. You need to tell us when we'll be ready the forward plan for the item self-neglect. I must say, through what I do in the community, one can link self-neglect with deprivation or with poverty. Self-neglect I'm seeing in areas where people would be considered to be affluent. It's quite disturbing, really. Particularly where there's been a relationship breakdown or death. Do we have a police person yet?
We do. I was, before we do, Ian.
Yeah.
Davidson.
John, can I just add to what you said there? The other thing is you can have affluent areas, but actually you can have capital affluence, but actually deprived in terms of income. And therefore they can be isolated, and therefore that can also add to it. So it can be a mistake to think an affluent area that's not a problem. I know you wouldn't think it's not a problem because of that issue around capital affluence, but poverty in terms of what's behind the curtains.
Yeah, and there are lots of dimensions to it, which is why I think we have the conversation in the right place and then bring it back here. I mean, remember, people can have capacity and choose to self-neglect. So we have to.
Can I just ask a question, John, if I may then?
I'm going to have to move on in a minute here.
Just very quickly, it's about how we make sure that we get representation from those areas which may not be the bleeding obvious. So I'm thinking, I'm being parochial now, and apologies.
No.
How we make sure we get representation there.
That's a sickeningly good point. Really annoying.
I do it occasionally.
I worry about the safeguarding board as it has a particular population.
Can I ask you, sorry?
And I would ask, I don't want to get into debate here, Deborah, could we please make sure that when you have the debate, we make sure we reach out? Deborah.
Yes, yeah. I just perhaps I can catch up with you in the break-in and you can give me some wider explanation around the representation side of your point. That would be helpful to me.
I think there's some very useful people in the voluntary sector. There will also be people in the standard.
We do, yeah, we have representation.
Right.
From voluntaries, the voluntary sector, wide representation.
It feels as if I had dropped the curtain on a very good item in the show, and then suddenly somebody's popped in front of the curtain again to grab the microphone, Mr. David. Right, BJ Harrington was due to give us the update on Right Care, Right Person. He has nominated in his absence.
In his absence, Assistant Chief Constable Lucy Morris, who's on the
Lucy,
line.
good morning to you.
She's muted at the moment.
Lucy, good morning. Cannot hear you, Lucy. No. Actually there, or is it a picture of her?
It's
Right.
joined by phone, actually.
Going by phone. Looks like she's muted.
Oh,
Yeah.
hang on.
Yeah.
Just got you, England.
That's it.
Apologies. Good morning, Chair, good morning, Board. Huge apologies, firstly from Chief Constable BJ Harrington for not being able to be here. Unfortunately, he is chairing another executive level meeting and asked me to deliver on his behalf. And apologies from me hugely for some IT and technical issues that have almost defeated me this morning, but I think we've just about managed to get through. I now can't see you, so can I check you can hear me okay?
Very loud and clear, thank you, Lucy.
Okay, good. Hopefully you've got a presentation that has been submitted in advance. So I will walk through some of the key points, but I think if I can just say that 12 months ago, my Chief Constable and my predecessor in role, ACC Kevin Baldwin, I think attended the board to introduce the concept of Right Care, Right Person. Since then, we've clearly embarked on a programme of rollout across the county in Essex, as have other police forces across the country. So 12 months on, this is an opportunity to update on where we've got to progress implementation and also around some further next steps. So if I...
Lucy, can I just suggest, because we have all read the paper, would it be of help if I just take any particular points of concern around the room which you could then address when you speak?
Of course, yeah, happy to do that.
I think it makes best use of time. So, Helen, are you okay? Because you had some
Yes.
concerns early on.
So, Lucy, it's Helen.
Explain to Lucy who you are.
Morning, Helen.
Lucy knows me very well.
That's me in my place, isn't it? Yes, carry on, Helen.
So obviously when Right Care, Right Person first came out, we were a bit concerned in Children's Services about it because obviously we have very established processes of dealing with concerns, particularly young people that go missing and absent, and it was getting a bit muddled. But just to say, we really appreciate the work that your officers have done. I did a call round to everybody who previously had concerns, and everybody came back saying it's calmed down, it's fine, it's right. It's not being used inappropriately, or if it is being used inappropriately, as soon as it's challenged, people are going, yeah, we're going to use the missing arrangement or mainstream child protection arrangement. So just really reassured that what we have put in place for Southend, Essex and Thurrock seems to be for children and young people, seems to have really calmed down. So thank you, Lucy.
Thank you.
Thank you, Helen. If I can just respond to that point, Chair. We were really keen with our approach in Essex Police that this is a partnership initiative. We wanted to work closely with partners to try and incrementally smooth out concerns and deal with issues as they came up. So this has been quite a gradual introduction rather than a big bang, which some other areas have taken a different approach, and we particularly listen to the concerns around children. And whilst we still maintain that right care, right person is about making sure that the right agency and the right support services is responding to a particular incident, which isn't always appropriate that it's police officers in uniform, particularly if it's a health matter. Actually, the fundamental principles of children's safeguarding still need to be maintained, and it's about what is right for that individual child and making sure that collectively as agencies we're putting the right support in place. That's been reinforced now by national guidance around dealing with right care, right person for children. We've benchmarked that with our policies in Essex, and we're really confident that through working with partners it is landed appropriately and is being used in the right places. But thank you, Helen, because that's really reassuring to hear from your perspective as well.
Excellent, thank you, Lucy. Other points around the room? Right care, right. Lucy, I'm not hearing anybody say they have anything to say, and nobody's spotting hands being raised. No. Tom Abel, Chief Executive, Mid and South Essex ICB. Tom.
Thanks, John, and thanks, Lucy. It was just an observation, actually, based on the very first agenda item in terms of looking at some of the issues that you set out within your slides. Is I think we need to make sure that some of this is hooked up with the wider mental health strategy work that's going on at the moment. Because I think there's clear overlaps and opportunities for those two things to reinforce one another in terms of supporting the ambitions of right care, right person, which I completely get, but equally also understanding how we effectively manage the responsiveness of mental health services, because the capacity and transportation kind of concerns and issues I completely recognise that you raise within your slides. However, we equally know mental health services are under quite significant pressure and don't also operate in isolation in terms of the wider partnership working that we need to deliver on. So I'm just thinking maybe looking at Ian, that's something we could look at doing in terms of linking these two pieces up, and so they are mutually reinforcing each other to deliver better benefits for the people of Essex. So yeah, just an observation from me, John, in terms of how we might take some of this forwards.
And Lucy, I don't know if you know what we're talking about. I don't know whether you've seen the full meeting papers for this morning, but if you can get hold of them, I will send them to you. Item 1 is around the strategic priority in our county strategy on mental health. And I think that's an excellent point, Tom. Right care, right person might deal with the here and now question of how it fits with the longitudinal piece of somebody's avoidance of crisis or even greater crisis. Are you okay to pick that up?
Yeah, if I may, I think it's a really interesting point, and actually, to use a kind of a hackney expression, it does the knitting. It's actually what we were talking about in the first one, is about how do we, in isolation, all these things individually say, oh, that's all great, that's all great, you know, then we all go off and do those different bits. How do we do the things that have a much greater impact? And it's in the health and wellbeing strategy, it's there. The support, a lot of the examples, and Lucy, you won't have heard it probably, I'm sure you could, but a lot of the examples actually I was throwing in on purpose was Brexit, and there was around policing, was around that. So you're absolutely right. I was just fascinated to kind of thinking about those links, but you've articulated it absolutely spot on.
Thank you. Catherine May from Epping Forest.
Thank you very much, John, and thank you, Lucy, for joining us for today. My question is very quickly on the key data slide, which is page 139. I think overwhelmingly the data is positive and it shows sort of some good reductions. The question I had was around the time spent on the section 136s, which now averages 7 hours. I wonder, how does that compare to pre-implementation of the right care, right person policy?
Oh, testing question of the data I haven't got in front of me. It was significantly higher. Forgive me, I haven't got the exact figure, but it would have been probably much closer to the kind of 12, 13 hours from memory. We are still actually higher than some other police force areas in relation to our time spent on 136. And that's exactly to the point that's just been made. around those integrated mental health services, because a lot of that is still availability of mental health beds. And actually one area where we are still struggling to make real progress is where we'll have people within police custody who we get to a stage where they've had a mental health assessment, they need to be moved to a section. We've finished the end of their police custody period, and therefore they move on to a section 136 so that they can be detained safely before a bed is available. So it's so important that those services are joined up, and where you see in other counties they perhaps reduce that figure even further. It is often about bed availability, which no criticism here. I understand how challenging that is, but why the two things are so intrinsically linked.
Thank you, Lucy. Next one is Ian Tompkins from Hearts and West Integrated Care Partnership through West Essex. Ian?
Yeah, a very quick point, Chair. I think in practical terms, it's about having and ensuring you've got robust pathways in place for dealing with incidents and preventing them. Having been out personally on a couple of ride-alongs, I've seen this with Harlow Police. And also, we're doing a lot of work led by colleagues in EPUT at the moment, together with Mind and the other support police, Princess Alexandra and so on, to develop what we're calling a distress pathway that in terms of self-harm, suicide prevention, and ensuring that people do get that right care and support and don't just get discharged only to go around the whole loop again.
Thank you. You heard all that. Lucy, did you all right?
I did, thank you. And the one point, if I may, Chair, the one other point I was just going to add is that actually that as we continue on this journey, one of the new initiatives that will start to replace police attendance at all around mental health crisis will be an increase through EPUT and other colleagues around mental health ambulances. And actually that is absolutely critical, because it's about individuals having the right care at that first point of contact, removing policing from even coming into contact with people who are in a health crisis, not needing law enforcement. And that is coming into being from April next year, and I think will make a huge difference.
So Lucy, you'll see that the group in the room here have demonstrated that they have indeed read the paper, and we've had a very good exchange there. At given time, are there other additional key points you want to make? I'm being prodded.
Yes, got to Anna Davey.
Right, okay, so I've got, can I just check, is there anybody else about to raise their hand? And I'll take the last questions. I'll take Anna.
That's it.
Right, so I'll bring Anna Davey in, and then I'll leave you to answer and make any concluding remarks, Lucy, okay? Anna?
Thanks, John. So I was just struck listening to the conversation and seeing things from a general practitioner's point of view, that one of the real issues for us with supporting patients with mental health conditions, self-harming and suicidal ideation is the lack of support for patients with personality disorders. So, we are aware that, I think certainly in my own practice, that there isn't the support for patients with personality disorders, who are often those patients who are presenting repeatedly in crisis. And I think if we take this right back to basics, what we need is much more community mental health support for patients with personality disorders, which will support primary care to support those patients better and avoid them actually ever getting to the point of needing these Section 136 interventions.
That slight dichotomy between mental health and personality disorder I find very useful. Lucy, I should explain that Anna is one of our primary care representatives. She's a GP, so.
Thank you, and I completely agree, and I think that goes back to that very first point that was made there around the integration of wider mental health services, and I think that's really key, that's not just around EPUT and acute care, and it's also about mental health in the community and trying to prevent people reaching that point of crisis. So I think exactly that joining up right care, right person with wider mental health provision and trying to make sure that they knit together is the key point. If I may, the final point, just probably add, one of the things that I was really keen to make sure that we did at this point, having been operational for 12 months, was to not just look at the data, but also look at some qualitative assessment as well. So there's a piece of academic work that we're looking to move forwards, and will include part partners in to look at the wider piece around how this has benefited. And I think the voice that I'm really keen to hear from is also around service, because the whole driver behind Right Care, Right Person was about giving the appropriate care from the appropriate agency. So really important that we try and pick up the service user experience as well. That's being led by Anglia Ruskin University. So very keen if anyone wants to have a representative involved in that work, then happy to have names to put that forward.
Thank you, Lucy. It's been very useful. And that last piece about mental health community services, Nick, I think the County Council, Peter Devlin's team have a role to play in that as well. So I'll leave that with you. It's worked out very well, Lucy. We had the technology issues, but then that enabled us just to come in and have a really good exchange rather than just a presentation, brilliant as I know that would have been. Thank you very much for your attendance. I don't plan to schedule another item of this. I think it is up to you to tell us when, if and when you need another one. But it may well be that the next time we consider this is in the context of the wider issues, Ian, that we've discussed this morning. Thank you, Lucy.
Thank you for your patience. Thank you.
Oh, no, it's fine. Thank you. We're going to keep moving on, if I may, into the leader. So our job here is to receive the annual report, but also to look at what the plan is. It's not our job to approve the plan, I don't believe. That's been agreed. That is the plan. I think Andrew Graham's talking to this. Are you, Andrew?
Yes, thank you, Chair. And thank
Andrew.
thank you, board members.
I think the piece for me is you don't need to go through all these slides. Just can you explain to us how this plan will have the impact we desire in achieving greater longevity for those people with learning disabilities, where we're not really moving as fast as we would wish to? Inspire us with the difference, Andrew. Okay.
Yeah. So last year when I reported on the annual report, and we also talked about the last year of the deliverable plan, there was scrutiny from the board around what would be impact and what did we need to happen. And during that time, I mentioned around we'd lost a lot of key people over the period of time. So what we've done by developing a 3-year deliverable plan with 4 priorities for each year is that we've got that to run alongside the action plan from the annual report. So there's 14 actions in the annual report. The key driver from it is, in the first instance, is for the deliverable plan, we have Southend, Essex and Thurrock leader champions. So far, we have 48 across 15 organisations. They're going to be key to driving forward the actions that are outlined within the annual report. In the annual report, we've looked at areas that are really key. So we've looked at aspiration pneumonia, which remains our largest killer in the area. We've seen really good progress already. The Essex County Council Provider Quality and Innovation team, based on leader information, decided they were going to do 2 aspiration pneumonia conferences for Southend, Essex and Thurrock, the first of its kind in the east of England, and other areas are looking to push that forward. So we want to drive the momentum. So some of the recommendations that we've got in there around postural health that used to be really kind of big and pushed forward to instill the importance of good posture in terms of the risk of aspiration. We've mentioned in the action plan around raising the profile of dentistry and championing the needs of autistic people and people with a learning disability because of how key that is to aspiration pneumonia. Our other biggest killer in the respiratory illness world is pneumonia. So we've really put a push on the pneumococcal vaccine, because pneumococcal vaccine is a vaccine that's usually seldom only offered to people with who are deemed by a GP or another relevant professionals have the relevant need, or over the age of 65 or under the age of 2. There's 2 different ones. But we worked with the community acquired pneumonia group within the east of England, who wrote the letter to all of the ICB CEOs to basically say that the pneumococcal vaccine is something that could be used for people with a learning disability and autistic people to help try and reduce the preventable death. But that vaccine will also help with sepsis. And this year we've seen a rise in sepsis. My predecessor did a lot of work on sepsis, and it was very successful to get the number of sepsis deaths down. Now sepsis is coming back up, it's really important that we start to address those. A lot of really positive work has been done on mental capacity at assessments, and also DNA CPRs, do not attempt pulmonary resuscitation. But we still want to push that forward to make sure that although the majority that we're seeing in reviews are right, that people do have them. We've also got forums across each ICB area looking at annual health checks, because they are the North Star in people's year. They are the opportunity to review medication, and they're the opportunity to keep physical health on a good trajectory or try to reduce the decline in people's health. And also they're there to be a gateway into other services via reasonable adjustments, and also to give people the confidence to access other services. So what I would say with this year's annual report and this year's deliverable plan is, because they are meant to run in tandem, there's more linkage between the success of the deliverable plan should help give more momentum to each leader annual report plan. And we're doing a lot at the moment to get more people around the room, because we've lost, I guess, some representation from some of the panels and that, but it's been quite successful when we've been talking to people about leader, that people are really enthusiastic about making a difference. Because although the average age of death has gone up very slightly this year after its big decline last year, we want to see more progress, and we want to remove that 20-year discrepancy. So I think that's the way we start, is we start by looking at the primary causes of death and all of the other additional factors that can really make that difference, and try and drive it forward as far as we possibly can.
Just listening to you, if I may, from the chair, which is a bit naughty, really. I heard a lot of things there. I just, if you go back to the earlier piece about self-neglect, and you know, I've often talked about the member of my family who died because basically he thought you got a sore tummy when you got older and didn't realise that it was stomach cancer. And he didn't look after himself very well. How do you reach into that population if you think there are people who might be out of touch and might be neglecting themselves?
Well, what works really well into reaching into those kind of populations is a lot of work previously had been done between health and social care around ageing well and plans for ageing. But also there's some really good resources in the hospitals, which are the learning disability and autism liaison nurses. And they're kind of an opportunity to help push people and push people to services, and also to have those discussions with them. Because I think nobody likes to look at in the general population what might happen as they age, but it is really important, because people with a learning disability and autistic people can become frail earlier. So it's important that they have those conversations, but the only way they have those conversations is if you get them access through reasonable adjustments to services, because it has to be trusted people, I think, to have those conversations.
So do they do outreach? I can see that they have an interface when somebody comes into hospital. I'm just worried about the people who are out there that they don't know that they are, type of thing. They're lost to view.
Yeah, but there's
Anna, from a GP viewpoint, do you do any outreach to your LD population?
So patients with learning disabilities will have their annual health checks within general practice. So, you know, we have the opportunity to have those conversations about prevention of problems, early intervention, ageing and so on as part of the annual health review. I would say that previously I was aware that there were more community learning disability nurses available to our patients, and I don't see as many of those nurses around at the moment. You know, sort of the last 10 years or so, there seem to be far fewer of those, but it may be that they're working in a different way and I'm just not coming into contact with them as often as I used to. But in particularly complex cases, we would work closely with the community learning disabilities nurses.
If somebody doesn't respond to their annual health review invitation, what you go back about, but you can only do so much.
Yeah, well, we'll carry on trying to engage with those patients and get them to come in, but that's the beauty of general practice. We'll often know people and we'll have built up a relationship with them.
Okay. All right, that's fascinating. Pam Green.
Yeah, thank you, Chairman. Just to add to what Anna said, we've trialled an initiative with the additional roles reimbursement scheme in primary care in Brentwood, and have got learning disability specific occupational therapists working in and out of the practice to support exactly as Anna said. And it might be that we take an opportunity to bring those partners into the room and share some of their findings. Because actually what they've done is done exactly that, the reach out and in. So engaging, making reasonable adjustments in the practices, working with the GPs around the literature, also helping people attend general practice, attend hospital appointments. And we've done a big health day in Basildon as well, where we brought all of those invited everybody on the register to come, have a further health check, etc. It's worked really well with the occupational therapist approach. And they're a partner called Sports for Confidence that have been developed as a trusted partner through the Sport England local delivery pilot. So it does close the loop on the physical activity as well as this particular sort of issue that's been raised.
Weak chairmanship has been beginning to run behind. I'll take Lee Scott and Councillor Hughes.
Thank you, Chairman. Mine is a question really, which I hope is appropriate for here, but from what I've heard, if somebody who has dementia and it's reported to their GP that this person is still driving, is a danger, what should happen?
Okay, can I come back to it because it's a bit different from LD, but I'll come back to it. Councillor Hughes.
Yeah, I mean, I can probably take a bit of Lee's point with my GP hat on, but I just wanted to echo what Anna has said, actually. I think certainly post-pandemic, we've seen a palpable reduction in the number of community LD nurses. I know certainly within my practice in West Essex, we have been able to achieve 100% reviews of our learning disability patients. And actually, it very much epitomises the relationship-based care approach that we adopt in primary care. So it's no doubt a very difficult to reach group. John mentioned about what happens if they DNA or don't attend their LD reviews. We have a very robust recall process, which actually, is overseen by our ICB as well. So we are required to report the number of LD reviews that we carry out across every single financial year. And if there's sort of targets that haven't been achieved, again, it's flagged up to the ICB as well. Just to pick up on Lee's point, it is notified to the DVLA, and DVLA as the regulator make a decision about whether to revoke the licence of somebody who's a dementia patient and whether they're safe on the roads or not.
Well done, thank you. Nick, a closing word, and then I'm going to have to move on, I'm afraid.
Yes, thank you. So remembering that Andrew here is not responsible for many of the things we're discussing, he's simply reporting on them, I think is something we should recall. So first of all, I would say what should concern the board strategically, has the shift from specialist learning disability services to general services worked as we would have expected? So we have decommissioned over many years what were specialist services in the hope that a more universal approach, which is in line with the social model of disability, would give us the outcomes we want. I think what we're hearing is it might be worthwhile having a look at whether that's worked. The most important thing for people with learning disabilities are their health checks with GPs. I think we've made a lot of progress. They used to be stockpiled and all done at the end of the year. No, they're not. It is difficult to get there. You probably need twice as long in attendance. The transport has to be organised. It's difficult to, so that's a really, really important area for us to continue working together on. In the report, I think there are some statistical variations that we need to think about. The West Essex life expectancy is 53. The North East Essex life expectancy is 62. I don't believe that is the case. I think there are some methodological issues going on there. I think that's about how we're reporting. I think we need to get underneath that. I suspect that actually they'll be fairly similar, but we need to get behind that. Too many people are still being admitted to hospital with a learning disability and dying with a do not resuscitate notice. It's something we should be concerned about as well. And far too many people with learning disabilities are diagnosed at the end stage of their disease rather than being picked up early, which relates to the health check piece. So I think they would be the issues that would sit between us that we'd want to focus
on. Andrew, you've got quite a lot of feedback there to yourselves, and it's not our job as say to approve the plan. What you are hearing is the desire to work with you and to those who are responsible, as Nick points out. Our last sentence from you, Andrew.
Just to say, we'll take that all on board, and when we come back next year, we'll make sure that we report in explain the methodology as well, or how we're creating average age of death so that people can see that.
I think I might just suggest you may want to drop a note round those people who have asked about the age difference that Nick's just mentioned. There will be curiosity for that. But let's just make sure. It would be really good if next 3 years we can achieve a breakthrough on this. Okay. We were a few minutes late started, but don't want to break into the workshop too much. So I need to go at pace, please, for the alliances. So I'm going to go west to east, basically. So west is, who's doing it? Ian? You have a maximum of 3 minutes, or else you will be cut off.
Sorry. That's me, Elizabeth Kirby. Hello. So in West Essex, I'm the new development director. I've been in post for about 6 weeks, so I've got a large remit to get going with rather quickly. So we're trying to finish our governance process and setting up our subcommittees so that we've got the right information going to the right places and the right decision making. What's really important for us is to develop the culture of the partnership working. It's really good at the executive director level, but we need to get more into the organisations at a senior manager level so that they're all thinking partnership approach and partnership discussions when we're looking at redesigning care for our population. In terms of delivery, you've heard quite a bit in some of the reports earlier about our 25% reduction in admissions for frail and elderly patients, and that's a really big piece of work that we're looking at with our Care Coordination Centre and the Falls Car and various other initiatives. And that's
what time scale, the 25%?
Within the next 2 years, but we're looking to try and reduce it over this winter as well. But some of the plans are medium term and some of them are more immediate. So this winter will be the immediate and some of them are medium. And it does depend very much on the integrated neighbourhood teams, and they're much more developed in some areas like Uttlesford, who've already achieved that reduction. But in other areas, they're more embryonic and they need more development. This is integrated obviously with our urgent care strategy and also with other programmes of work for areas. And then in healthy life expectancy and health inequalities, we're launching our prevention program. And the priorities are very much similar to the ICB and the Health and Wellbeing Board's approach, with a major focus on healthy weight and oral health. And we're about to launch the 5 Dinners website for Harlow to really emphasise cooking and healthy eating. And we have a couple of trips to go and see how other people are doing things better than us or more advanced in their progress. So we're going to Bicester and I think we're going to Tendring as well.
Thank you very much. I'm sorry, just to keep pushing on. If I come down, I've come down to Muttersford, Harlow, I come into Brentwood and Basildon. Is that Pam?
Yes, it is. Yeah. So thank you, Tim. I think from the last update, we continue to work on the integrated neighbourhood teams. Most notably, we've had our health inequalities first review of the monies that we've deployed at place level and a really wide range of initiatives that have gone out supporting youth groups to elderly groups to myotis, working with children with disability, etc. So really pleased and supporting the CVSs to work together across Brentwood and Basildon to deploy those funds on a delegated responsibility for the committee. You'll be pleased to hear, John, that we are in the process of appointing an independent chair now that we've matured. We're nearly 2 years old in Brentwood, so we're the baby of Essex from an alliance perspective. So we're working on that to normalise the chairmanship across the rest of Essex. And working very closely with our GP practices, as I say, with the integrated neighbourhood teams, with a real focus on the Frida tool, which you have had presented here before, around frailty and holistic approach heading into winter, so that we are identifying our most vulnerable and looking to reduce their demand on services, linking also with the end of life teams. So.
Thank you. I could ask you a dozen questions, but there we go. If I go from Brentford to Basel, I can Rochford and Castle Point, which must be Becky.
Yes, John. So as I reported last time, as an alliance, we were working on our delivery plan. We have now agreed our delivery plan focused on healthy neighbourhoods, of which integrated neighbourhood working is central to that. And we have prioritised Healthy Start, Healthy Living, Healthy Minds and Healthy Ageing in order to deliver that. I think it's important to say PAN alliances across MSE. We continue to work with our local hospitals and the managing directors across the patch to support our system recovery, particularly looking at flow and how we optimise our levers and services across the system to support a home first approach. And that enables really looking at how we kind of maximise the community support through our transfers of care hubs, but also looking at the new models of care like virtual wards and virtual hospitals to enable that, John. So I think alongside that asset-based approach that Pam referred to and what we're doing with our inequalities fund, that's been our main focus.
Absolutely. Thank you very much. I've left Rochford and Castlepoint, travelled up. I hit Malden, then Chelmsford and Braintree. So where do we have Dan Doherty?
Dan's not well, unfortunately, so he's not here, John, but on his behalf, they continue to work with the Thriving Places approach. They've taken a lead for us as an ICB in the community contract development as well. So wrapping the relationship around community services with local authority and back down into place and PCNs. I think that's a very notable development at place level for us because it's hardwiring the contracting into place then. Yeah, there's significant developments obviously around the Thriving Places work, which I know Dan has spoken about before and has offered previously to discuss with the board if required again.
Thank you. Do wish Dan well, and then we meander up into North East and we find Laura.
Yeah, thank you. So at the last meeting, I said we'd be establishing a healthy behaviours group. That meeting is going to start on the 1st of October and the group is co-chaired by Ben Hughes from Public Health and Jason Fergus from Active Essex. And it will allow the Alliance to have a real link into the joint health and wellbeing strategy, but also the prevention agenda through the Commission Public Health Services. So we're really pleased to be doing that because it brings in new partners. We've got a Better Care Fund workshop with colleagues from Essex County Council and our providers this Friday, looking at reviewing the schemes and the evaluations and making plans for next year. We're strengthening our relationships with our councils, as Ian said, through the active wellbeing, and I think that work is moving into sort of practical delivery, so that's really positive and taking us in a different direction in place. Lynn is here, is my deputy, who's been leading on resilience and planning, including the reduction in primary care and acute services through acute respiratory illness through the winter, and that's driven by our population health management data. We're progressing with our health inequalities funding, with our first bids going through governance at the moment, and they align to the core 20+5 national priorities, but also the local evidence, including suicide prevention, COPD, childhood asthma as examples. And then our place-based plans will be socialised over the autumn. These documents will give us an ability to focus on the next 5 years, linking into the joint health and wellbeing strategy for Essex, the joint forward plan of the ICB, but also the corporate plans for both tendering and Colchester councils, but also looking at how we can work more closely across the system, including with the North East Essex Children's Partnership Board.
Laura, thank you. And can I thank every one of you? I am hugely mindful that the alliances are all sit within your respective ICBs. I am equally mindful that these are the catalyst to true place-based working and shaping the agenda of the various strategies towards the needs of that population. Can you please continue to try and help me know how best and what is the most appropriate interface you have with these meetings? Because I could have filled the half the agenda with questions for you all, but thank you very much. Please don't take haste as an indicator of value. It's very important. Thank you. And for those who are feeling starved of caffeine, we'll keep going, if you don't mind, a bit longer until we let you refresh it. You're not far away. We've got 2 items left to do, then we're going to do the briefing for the workshop, at which point we'll then have the ability to have coffee. If you're absolutely starving or have other reasons of personal hygiene, please just go. But in the meantime, we are now making an appeal to all of you for your help. And that's to do with the fostering friendly employment. I think I always knew that fostering was important, but it's only when one's exposed to it as a cabinet portfolio holder that you realise. I don't think any of us would doubt that we would want every child to grow up in a family setting wherever that is possible. Our children's services work with the system to minimise the number of children for whom that is not the case, and have had huge success. And the great majority of children in care, young people in care in Essex are in such situations. However, firstly, we have more who could be fostered than we have foster parents for. Secondly, we are struggling to keep population growth of foster parents growing, as we have a large proportion of them aged over 50. And thirdly, where there are fostering parents, we will achieve better financial sustainability if we can enable populations of foster parents within our own community rather than paying external agents. And so the ambition of the service is to move to, as far as possible, all our anchor providers across the county, as well as private business, but let's do one step at a time. Our anchor providers across health, across police, across local authorities. And between us, we employ the greatest bulk of the Essex population to move into foster-friendly employment practices. We've started in this council. We know we've got more to go. And then we wish to say something.
So I just want to say, obviously, it's a big plea. We want people to think of fostering in a different way and think of your staff as being able to be foster carers. We know it takes a long time for people to become a foster carer because you've got to think about it, got to have the space for it, and then you have to take the leap. We know it's really, really impactful for both people that become carers, but more importantly for the children who end up being cared for in this way. Julie, do you just want to kind of run through the bit? I don't can see you put up the presentation. Do you want to just run through quickly or?
Yeah, we're very constrained on time, Julie, but give us the key points. And maybe just help people understand the policies that Essex is adopting to try to make this easier for people.
Okay, I'll skip because thank you very much for the introduction. I think that the first few slides that I've got, it was laying that groundwork. So I will just go I'll go straight on to how Essex Partners can help, as well as businesses and organisations across Essex. We really, it's a plea really today to help us find more families who could foster and change children's lives. There's all sorts of ways in which different organisations can do that for us. Very simply by promoting the need for Essex in-house foster carers through any of your social media platforms, through newsletters, or a big one, and this is my major ask today, is consider becoming a fostering friendly employer. So fostering friendly employer is not an Essex scheme. This is a scheme that is operated by the UK's leading fostering charity, which is the Fostering Network. We became a fostering friendly employer earlier this year, joining a long list of other local authorities and other organisations such as the Home Office and big names like B&Q, John Lewis. All of those kind of organisations are fostering friendly. The Fostering Network's research shows that nearly 40% of foster carers in the UK successfully combine fostering with other work. So we really genuinely don't believe that being a foster carer is sort of conflicts with being employed within other organisations. And we're very clear that having an employer who understands and respects fostering is hugely beneficial to employers who are foster carers. So the scheme offers organisations and businesses of any size the chance to make a difference in their local community, It improves, the idea is really committing to improving the support for employees. And it's very simple. It's essentially allowing time for employees to become registered as foster carers, so up to 3 days, additional leave so that they can go through the recruitment process. And then once registered as foster carers, assuming they're actively fostering, allowing time off in order for them to attend meetings for children, attend relevant training for the role of fostering, so up to 5 days.
And really sorry, we could send the presentation out afterwards, okay? You can sort of make sure you're coming to the key points. I think you are.
Yes, I mean, that is the key point really, is essentially really trying to encourage people to join the scheme and to consider joining the scheme. You can also, if you're not wanting to do that, there's other ways in which you can help us through sharing your content. We've got posters that you could display in your offices. You could share social media content. We've got lots of content that we could provide you to share within your streams. You could offer us space for information events so that we could come and talk to your staff about being foster carers. We've got lots of different ideas. We've got, a whole toolkit of stuff that we could give anybody that's interested in joining us. And that's essentially it. I've got a couple of examples of films that we could show you to kind of give an idea of the kind of content we've got. And there's the end slide is ways in which you can contact anybody in my team who could work alongside you to either kind of, get social content or to think about how you might become fostering friendly, joining the fostering networks. That's essentially it.
Following this meeting, we will send out to all the organisations in the Anchors Network, firstly, why it's imperative, the business case in brief terms. Secondly, the slide presentation with practical things you can do as an easy way. And I hope everyone will see that being a fostering friendly employer is an enriching proposition for your staff of all sorts, because it shows your commitment to the wider community needs, okay? And I would really want to say to all of you who are leading major organisations, we will do everything we can to help. And if you need us to come out and set out the business case, we'll happily do so, okay? Are there any immediate questions? You've been very patient. I'm sorry, it's just blasted this last half hour at you.
Yes, Sam Glover.
Sam Glover.
Thank you. Great presentation. Definitely want to be, I'm a minor organisation, but would definitely like to be foster friendly. If you can share the digital assets with me as well. Yes. I think this is something we could promote for our men's networks as well. So if you could tag on to our fellas events, that would be fantastic. We're doing talks at big employers such as Eelander about opportunities for men. So it'd be great to tag on to that as well. We're also doing a project on care leavers starting towards the end of this year. So I think having that lived experience from both sides would be really valuable.
Thank you, Sam. It's a great offer. Thank you.
Ian Tompkins.
Ian Tompkins.
Yeah, very quickly. I don't know whether you have, I assume you have, but if not, I would recommend you share with the Essex Communicators Group and also the Anchors Network.
Well, thank you. I don't know about the Ian, but thank you. Can you pick that up, Julie?
Yes. What was the second one? Sorry.
The Anchor Network meeting. We'll invite you to we'll invite you to a meeting.
Thank you. Perfect. Thank you very much. That's excellent.
Anybody else? Right. I'm really sorry about the rush. We lost that time at the start. Beverly Egan, Councillor Beverly Egan, the chair of the Caring Communities Commission. It's a great joy to welcome you, Beverly, my great friend. You're going to explain to us what the Commission's up to. And then after that, we will finish the meeting, do the workshop briefing. So, Beverly.
I've just been encouraged to come forward. I was going to shout from the back.
No, come.
No. Thank you, John. Come on down, yes. Okay, well, as I look around the room, myself or my team have either spoken to you directly or corresponded with you. So thank you for the encouragement that I've already received for the setting up of the commission. A lot of work has gone on since it was announced in May. In the background, a work programme has been designed, and we had our very first meeting on Monday. In fact, there are 2 commissioners in the room. So it was full of energy, passion and commitment. The commissioners inputted into and made suggestions for us going forward. Listening to the agenda items today, and as many of you know, this isn't my first time at a health and wellbeing board, but again, I could just hear the things that are going on, where communities are at the heart of the work that you're all doing. So what I'm hoping we will be able to achieve over the next 6 months is to hear from as many people, engage with organisations, partners, service users, residents in a variety of different ways. And then I've been tasked with the Commission to produce an initial report in 6 months' time. So I might look a bit frazzled the next time you see me. So really my plea is for everyone here today to help us engage with as many people as we can. If you haven't seen our engagement programme, then that will obviously be coming out very, very quickly. But we've got 4 main themes that we're looking at, and yeah, we just want as much assistance, help, engagement, and so any suggestions you may have, we would be delighted to hear. I don't know if anyone's got any questions, and if they have, I'm sure Richard and myself will do our very best to answer you.
Thank you, Beverly. And I think we sent some packs out about the Caring Commission, don't we? I don't know what materials have been sent out, Will, do you? Did we send many papers to you on this item? I'm a bit lost.
It may just have been this 2-page briefing, but we can send round more material.
Yeah. Does everybody know who all the commissioners are? I think, let me please ask the Secretariat, Richard, can we please make sure every member of the board has a good briefing, the aims, the goals, the timescales, the members and so on. Because there's no point in this just going over all the ground that's been discussed before. Beverly's brief is to break new ground in taking forward the work of the Who Will Care Commission for the last decade. Yes, we will follow this up with a briefing. Yes, Richard.
No, I was just going to say, yes, we can do that, John. We'll share with colleagues the pack that went to the commissioners on Monday.
Great.
Yeah.
Sam Glover.
Thank you.
Sam.
Just to say, I had a great meeting with Claire Burrell and Chloe Livingston about this week, and I've shared all of the focus groups we already have running in the community that any councillor can come along to and ask some questions from the real people.
Yeah, lovely. And we've got a website, and so those that can access that, they'll be able to input directly as well. So thank you, Sam.
Thank you. The outcomes will be as good as the support we give you, Beverly. Anybody else? The very best wishes, Beverly. I think you're staying on for the workshop, are you? Because it's directly.
Exactly. Yeah, it's very interesting. Yeah.
Right, thank you. I think we've just about caught up, and I will apologise again for the fact I've had to curtail discussion, which I hate doing. We're going to do the briefing for the workshop. So if anybody is not staying there to share back with you, have we got many people joining online? You're signalling to them to come, and the briefing is being undertaken by whom?
I was just to say that before the meeting, all items should forward.
Right, so can we please note the forward plan, which will be further developed? Are there any other items of any other business? Which point?
Date of next meeting is the 20th of November, 9:30 AM. Same time and the same place. Yeah, that's it. And then urgent business.
I have no urgent business. I've been notified of any, so we close the meeting. And we move on to the briefing, please, for the workshop. And I believe that this is going to start off with a video from Ed Garrett. Yeah.
I think I've got some colleagues joining as well.
Right, so.
They're outside.
There, Ben, thank you.
Sorry, perceived as. You can trade the guide in, but you can't trade the guide out. Go to make
I was just considering. That was the time.
Thank you.